Hello, my name is Sue Stillwell, and you may recognise me or know me from the Menopause Clinic in Sheffield, where I've worked for many years. You might also know me from my role in contraception and sexual health, and I work at Retford and Worksop. And many years ago, I was a GP in Retford. So, Kayleigh has very kindly asked me to come and talk to you about HRT and to give you some top tips. Just my declarations, I have received funding from various drug companies to give talks. This is the content. We're going to talk about HRT that is prescribable on the NHS. We're going to talk about estrogen, progestogen and micronized progesterone, testosterone and vaginal estrogen. So top tips. So we've got 10 top tips today, and each one is fronted by a photo. And this is top tip number 1. And it really is to define what is important to the individual. When people come to see you with menopause symptoms or perimenopausal symptoms, they might have a whole cluster of things that are troubling them, some of which may or may not be related to the menopause. So it's really important to clarify what is important, what is a priority to that individual, and what they would like to change or improve, and what their expectations are for that. And that sounds very straightforward. We do it all the time, but I think it can be easy to forget that in a menopause consultation. Let's work out what you really want to improve. Which one of these many symptoms is actually the thing that's troubling you most? And sometimes people will say something that we may find really difficult to help with, like weight. And they are assuming that HRT is going to help them to lose weight that they're gaining as they're getting older and becoming menopausal. So top tip number 2, this would be to ask them to look at what outcome they would like. Not only what outcome, what they're want to see as an improvement, but what they couldn't tolerate is also something that is useful to ascertain. Some women who've had terrible periods through their life, perhaps have had endometriosis, really can't bear the thought that they might get periods back again if they restart their periods, if they start on HRT. So that can be a real stumbling block for some people. Weight gain we've mentioned, but many people fear putting on weight on HRT, and it may be helpful to check their weight prior to starting it. Other things like breast tenderness, women who've had terrible cyclic breast tenderness may be scared of getting that back again if they start on HRT. And similarly with headache and migraine, this might be something they fear being made worse. As you're discussing HRT, please talk about the benefits as well as the risks. I think we all try to protect ourselves and to make sure we've talked about risks such as breast cancer with HRT, and can forget to talk about the benefits in terms of quality of life, but also in terms of a reduced risk of things like colorectal cancer and of osteoporotic fractures and possibly of cardiovascular disease. So in terms of that outcome, how we're going to measure it, is it going to be that that person's going to come back and tell you how many hot flushes they've had and how they've changed? Does it need tests? And the answer would be no. This is based on symptomatology. It isn't based on an accurate blood test that's needed. There's no estradiol level that is right or best for an individual. So how will you review them and when? And it might be that you choose to do this via some form of questionnaire, but it might be that you can empower people to make changes themselves if they run into problems. Top tip number 3. So side effects, again, it's easy to forget the minor side effects when you're talking about risks of HRT, but common things, bleeding, change in bleeding needs to be expected, breast tenderness and bloating, mood change, headaches, abdominal discomfort, skin changes are all really common in the early months. They do tend to settle with time, but they don't for everybody. What about that bleeding? Well, we've got really good guidance now, which I think has made life very much easier, which is basically saying in a fit, healthy person with a BMI less than 40, if bleeding occurs within 6 months of starting HRT, that's acceptable. Also, if it happens within 3 months of a change of HRT dose or preparation. If it extends beyond that, then it needs investigating, or HRT needs stopping or reducing to see if bleeding will settle down. And that ultrasound scan should be performed within 6 weeks of referral. And that guidance is very clear and easy now. If somebody is having problematic bleeding, how would we manage that? That would be potentially by looking at the balance of the estrogen and progesterone in your HRT. Sometimes lowering estrogen, sometimes increasing or changing progesterone would be helpful. We know that oral preparations tend to offer better bleeding control than transdermal preparations. And the Mirena coil actually reduces episodes of unscheduled bleeding better than anything else. But although this is something that is very much promoted in guidance, isn't something that many women actually want to choose unless they've been coil users earlier in their life. So for those women where we're thinking there may be a problem, they may be migraine sufferers or they may have had breast tenderness, we can preempt some of the issues by starting with really low dose estrogen. And that should be transdermal because it gives much smoother dosing. And that would be looking at one spray or one squirt or a 25 microgram patch. And then you can look at increasing slowly after 6 weeks to make sure that troublesome side effects don't prohibit somebody from using and getting the benefit of HRT. The progesterone in HRT certainly can also cause breast tenderness and headache, so it's worth looking at the timing of the symptoms. Are they just when somebody's taking a progesterone on somebody who's on a cyclic preparation, or is it a constant problem? And sometimes it's worth moving route. Usually we'd use transdermal for women with these problems. And if they're on oral, I would definitely move to a transdermal preparation. This is a really common scenario. My HRT stopped working. So it's an opportunity for review. What is working? What is no longer working? What else has changed? Any new medications that could be affecting absorption? Is the gel drying well? Is the patch sticking? What other preparations are they putting on their skin if they're using a transdermal? Could it be a moisturizer or a suntan cream that's preventing absorption? Mounjaro obviously is the thing that many women are taking that might affect oral absorption, and there's guidance about how to manage that. So we might need to increase dose, and sometimes we need to exceed licensed dose. One of the ways that can be helpful in managing this is to set boundaries for a patient and say they can increase up to this point, in which point you want to see them to review what's happening. And that might be because you need to increase the progesterone to match the estrogen dose. You might also need to change route. Some people do better on oral rather than transdermal preparations. Top tip number 4. This is a picture of old man's beard. This is in a hedgerow, and it is actually a wild clematis. And the reason I've put it there is that we're going to talk about hair, and hairiness is largely genetic. We know that many women get increased facial hair by the age of 60, and the change is quite significant, with a lot more terminal hair on the upper lip that can be quite troublesome. Also, women will experience loss of scalp hair. And this is a genetic problem for most women and isn't going to be moderated by using HRT significantly. So lots of symptoms happening at around the time of menopause. Not all of them are hormone related. Top tip number 5. It's about resources, and there are some really good resources. You can't possibly provide the information that you need to in the quantity that you would want in a 10 or 15 minute consultation. It's really difficult in half an hour as well. So use the resources that are available nationally. Women's Health Concern is the patient arm of the British Menopause Society. Balance app is run by a GP called Louise Newson, who provides a lot of private menopause care, but she also provides some free information that is actually very, very good. Daisy Network is for women with premature ovarian insufficiency. Menopause Matters, another good website. Henpicked is a group that was set up for helping women in work and workplace management of menopause care. Queermenopause.com for those who identify as LGBT. The NHS websites have got reasonable information, and Rock My Menopause is one that's got good information about libido and sexuality. For us as clinicians, I think the Primary Care Women's Health Forum is excellent. The British Menopause Society guidelines and consensus statements are really good too. Top tip number 6, and there are 6 daisies there, just offer the safest treatment. It has to be safe, it has to be effective. The safest treatment that we have at the moment is micronized progesterone and transdermal estrogen. Now, that isn't always very convenient for people. People who find it a struggle to remember to take 2 products may struggle with this. People who are trying to take it cyclically may find it difficult to know when to take it, particularly if they have erratic bleeding. I often hear people who are saying, well, I waited for my period to take my progesterone. So that can be a problem. The other thing that we have nowadays is dydrogesterone, which we used to have many years ago as Dufaston. It's now called Nalvi, and this is a progestogen, but only one chemical bond different from micronized progesterone. And like micronized progesterone, isn't linked with any increased risk in venous thromboembolism. Comes as a 10 milligram tablet, and at the moment is only licensed for cyclic HRT, but is used for continuous combined, and is what we're used to using in Femiston products. So why is this combination safer than any other? Well, it's in terms of breast cancer risk. It's the progestogen that is largely the culprit in breast cancer risk, and the natural progesterones don't seem to show an increased risk for the first 5 years of use, and that applies to dydrogesterone and micronized progesterone. There does seem to be a small increase after that point. Estrogen-only HRT, as we know, has minimal impact on breast cancer risk and may actually reduce it. And it's important to be aware that the route of HRT doesn't modulate breast cancer risk. It's duration of use that is linked with that risk. Now, oral HRT is linked with an increased risk of venous thromboembolism and of stroke, and transdermal does not increase that risk beyond that individual's background risk. And that's why we are able to use it in some people with higher risk of VTE, and in some circumstances in those with previous VTE or with thrombophilia. Okay. What have we got in terms of transdermal estrogen? We've got Lenzetto spray, we've got patches, gels, and sometimes it's difficult to know what a comparable dose is between these different preparations, so I've put that down at the bottom. The spray goes onto the forearm, the inner forearm, and you generally would spray into the same spot, although it isn't saying that on the product information. That's the current guidance because it creates kind of a reservoir of estrogen. The patches, generally on the thigh, they do leave sticky marks for some people, which they find quite frustrating. The gel, inner thigh, shoulders, for some people it takes much longer to dry than for others, and that can be a problem if you're using a lot of it. Micronized progesterones. So at the moment we're saying this is the safest progesterone component. It's bioidentical progesterone. Although the progesterone is plant-derived, the capsule actually contains gelatin, so it isn't suitable for some people who prefer to avoid meat products. It definitely improves sleep when it's taken orally, hence you should take it at night. However, some people do find that it affects cognition, so it may be better to use it vaginally, though out of license. Although it's natural, it does certainly have side effects, and some people have nausea, reflux, perhaps changed cognition with it. Compliance can be a problem, as I mentioned before, because it's actually quite difficult to take, particularly if you're taking it cyclically. And we'll talk about that a little bit more. It does contain soya and isn't suitable for those with a soy or peanut allergy. How do you take it? Well, the way that we generally would prescribe it in a menopause clinic is different from the product information. We would generally say take it for 2 weeks out of 4 for someone who's using it cyclically. 2 weeks on, 2 weeks off, because it's so much easier to remember that way. For those who are taking it continuously every night without a break, we don't recommend the 3-day break that's in the product information. If it's taken orally, it should be on an empty stomach because fat increases absorption. And side effects, drowsiness, changes in bowel habit, nausea, reflux, and cognition. And I've got a couple of patients who just find that they are so muddled when they've taken it that they can't tolerate it. The Mirena coil, particularly useful in those who are perimenopausal, who are needing contraception. Some people believe that it helps manage perimenopausal symptoms on its own. There is no evidence of this, but some patients will certainly say they think it helps. When it's used as part of HRT, we would use it for 5 years, although it would be used for 8 years for contraception and removed at the age of 55 if it's only used for contraception. It is linked with a small increased risk of breast cancer, and that's when it's used alone or as part of HRT. We do have newer progestogens. I've already mentioned dydrogesterone, which is actually just a rehash of something we've had for many years. But drospirenone actually is new. We've had it in the pills in Yasmin and in a new pill coming through called Drovelis. And it is in the progestogen-only pill called Slind. It's a spironolactone derivative, and some people have suggested it might help with hypertension. But I don't think we're going to be using it in that context. Because it's acting on the kidneys, it's not suitable for those with renal failure. It does have an anti-androgenic effect, and it does bind strongly to progestogen receptors. So again, it may have better cycle control. So I see it as a place for those with bleeding problems or with progestogenic side effects. And the dose is 4 milligrams, is out of license. Within a Slind packet, there are 4 placebo tablets, and you would omit those. So it's for those who are on a continuous combined preparation and who are having problematic bleeding or side effects with the progestogen. Top tip number 7. This is about testosterone. So much in the press is this is the missing piece. This is, the one of the 3 hormones all women should have replaced. Is it? I don't think we have that data. We know that it improves libido, that women are finding is troublesome with a loss of libido. It will improve libido in about 2/3 of postmenopausal women who take it. Now, the data is for postmenopausal women, and most of the data is for women on HRT already, although it is used, particularly in Australia, as a standalone product. So the British Menopause Society guidance is it's for troublesome loss of libido only after other options have been exhausted. And that's a bit of an unclear statement. And it says they recommend a psychosocial approach. And that makes sense. We need to think, well, what else could be causing a change in libido? What's happening in that relationship? Who else is at home? What medications is somebody on? Is there an impact from an SSRI or a beta blocker? What's happening to the partner? Are there any erectile problems there? All of those psychological things should be considered alongside the option of starting testosterone. But the data is only for postmenopausal women, and like you, I'm sure we're seeing increasing demand in younger women with loss of libido who are wanting to consider testosterone. There is guidance from the British Menopause Society about testosterone. So that's the testosterone replacement information. And as you know, there's a shared care pathway with us in Sheffield. I know many of you may not wish to take part in that shared care pathway, and I think this is a discussion that we all need to have, because as a hospital we're not able to provide that ongoing prescription, so this leaves a woman with a problem. There's a gap in their care for those women who start testosterone and wish to continue it. As you're probably aware, there's no long-term safety data for testosterone, but in the short term, we don't see any significant harm at all, and all the data is very reassuring. For those women who are a bit younger or whose menopausal status is a bit unclear, we have to advise people to use contraception. They do need to have monitoring, and most often we would do a testosterone prior to starting, testosterone replacement, and again at 3 months and thereafter annually. And this isn't because there's a perfect or a right level we're aiming for. It's to ensure that levels don't become super physiological, because all the safety data is for women using it at doses that are physiological for premenopausal. In terms of side effects, don't really see very much that is sort of serious. Some people get hair growth at the site of application. Sometimes people get bleeding, irritability and mood change. Some people feel like they've got terrible PMT on it, so it's not for everybody. And you can advise people they can stop it if they wish to. In terms of what we have on the NHS, the two that we tend to use are Testogel and Tostran. Privately, Androfem is commonly prescribed because it's easier to use. It does have MHRA approval, but not approved for prescription on the NHS as yet, but it's hoped that that will come this year. An important thing to discuss with those people using testosterone is how to apply it. We generally say the outer thigh, and if they're using gels, put the gel on the inner thigh for the estrogen. It should be allowed to dry before any skin coverage. And then it's really important to wash hands well so that there's no transfer to anybody else. The area of application of testosterone should be washed before any skin-to-skin contact with anyone else. And ideally, that would be an hour or two after application. And when you're doing your testosterone levels, make sure they haven't used it before the levels are taken. So I would generally say if you're going to be using testosterone on the day of having your blood sample, make sure you do it after you've had your blood sample taken. As regards the blood levels, there's quite a fluctuation, so don't panic if somebody's levels are particularly high. I generally would just repeat them before I make any significant change, unless they've got troublesome side effects. Top tip number 8, this is about dry skin. Dry everywhere. The skin does get dry everywhere. Collagen is reduced, so we bruise more easily, and skin and hair are drier. So what about genitourinary syndrome of the menopause? Really common, and people don't talk about it. This is something you're going to have to ask about for your HRT users and your non-HRT users. And about 1 in 5 people who are on systemic HRT will have significant genitourinary syndrome of the menopause still and need vaginal estrogen. So it's safe to use both, and please reassure people that it is. It isn't too much estrogen. Do remember that the vulva may need treating as well as the vagina, so a pessary may not be enough. You may need a cream as well. And that's the advantage of using the creams with an applicator. Then you can also use some on the vulva. The disadvantage being they're a little bit messy. So management of genitourinary syndrome is really around common sense stuff, moisturizing, not sitting in bubbles and hot tubs for too long. Use of the non-hormonal products is really good. And then the hormonal products, there's a good selection. There's pessaries and creams and gels and rings. And there's even androstenedione in the version of progesterone, which is a little vaginal tablet. And this has estrogenic, androgenic and progestogenic effect. What about those women who've had breast cancer? The advice is to start with moisturizers first and really early after diagnosis, and to also look at using dilators or wands and vibrators to maintain stretchiness in the vagina. And if the moisturizers and lubricants aren't enough, to then consider vaginal estrogen. The data is very reassuring. There's been a very big cohort study of 50,000 women with breast cancer showing no increase in mortality in users of vaginal estrogen. Unfortunately, that big study didn't include women on aromatase inhibitors, and there was another study from Denmark for women on aromatase inhibitors showing a small increase in recurrence. So I think there is still a bit of a question mark, particularly for those women on aromatase inhibitors. Should they be using vaginal estrogen? If they choose to, they need to accept that we don't really know, but it's possible that it might increase their risk of recurrence. But that's a decision that they can choose to make, knowing as much as anyone knows about their risk. So in terms of treatment of genitourinary syndrome of the menopause, it's very important to recognise it may take many months to be fully effective and will need to be a long-term treatment. We've talked about the different preparations. Other alternatives would be ospemifene, which is an oral preparation that improves vaginal moisture and stretchiness, also improves sleep, but it does have an increased risk of hot flushes and a possible increased risk of VTE. Laser treatment is something that you'll see privately and really should only be done as part of studies, because the data as such at the moment isn't clear as to is it beneficial, and if so, to whom. Local anaesthetic gel is something that some people will choose to use, but it doesn't improve stretch, and that's a problem for many women. Top tip number 8, or are we number 9? Number 9. Let's have a little look. What about sleep? There's no doubt that HRT improves sleep, particularly for those women whose sleep is disturbed by sweats. The other things that work, CBT definitely helps. Using things like the Sleepio app helps. Melatonin is helpful in some women, and in the short term, Zopiclone. Ospemifene, this treatment that we said for genitourinary syndrome of the menopause, also has been shown to improve sleep and quality of life. It's such a problem for women as they become menopausal. Top tip number 10, and this is about those blood tests we talked about right at the beginning. Do we need to do blood tests either at the outset or to monitor? So basically, if we look at FSH, it's not useful in women over the age of 45 unless they've had a hysterectomy or an endometrial ablation, or who are on progestogen-only contraception and are amenorrheic, and you're really wanting to know if they're menopausal. So that might be a helpful time to do it. Just bear in mind that POI, premature ovarian insufficiency, that means menopause occurring in women under 40, is on the increase. And if somebody has more than 3 months of amenorrhea, do check FSH, and if that is elevated, this is an indicator of POI. You may choose to repeat it, but it's certainly indicating POI. Estrogen levels themselves as a diagnosis aren't helpful. They vary hugely. As a management in terms of optimizing treatment, there can be a helpful management tool when somebody is on maximal doses of HRT and are still very symptomatic. It's only useful in transdermal preparations, not in oral preparations, but can be helpful if somebody's right at the top, they're on 4 pumps of gel and they're saying they're still not better. Measuring their estradiol levels may help you to know whether their levels are good or not, because if they're very low, you may need to change route or increase dose beyond licensed levels. Or if they're good, you might be saying, well, actually, maybe estrogen isn't the answer to whatever problem you're experiencing. So I do estrogen levels, but only in that situation. So final thoughts. I am available for advice, and I now work as part of a much bigger team of other consultants. So there are more of us, but the demand is huge, and unfortunately the wait time for clinic is also long. Advice and guidance, really wanting to do more and more of this. I know this is a government push as well. Can you submit it via ERS so that it goes through the right process and then a record is put into the notes? Traditionally, I've responded to loads of emails from colleagues, but they're asking us to do it via ERS, so it's a process that's a constant and the same across the board. I know you asked me a little bit about HRT in over 60s, and the information that I would say is that People can continue with HRT for as long as they wish. That's an individual choice. For those who are starting HRT in their 60s or more than 10 years after their menopause, it's a very small group of women, but they're not going to see the benefits in terms of cardiovascular risk. But all of the big studies don't show an increase in cardiovascular risk for that group of women. I think those women should be on transdermal preparations rather than oral preparations, and you start at very low dose. That's because those women who have already developed some atheroma as they've aged, it's really important we don't destabilize that by adding in estrogen. So you would start very low and slow. And again, looking at a 25 microgram patch and a micronized progesterone because of VTE risk. So that's all from me. I hope you found that helpful.